Thank you, Professor Nguyen, for the kind introduction. So I'll talk about neuromyelitis optica spectrum disorder, or NMOSD, which is a very, very much different talk from the previous 4 talks we have heard today. So we know that in multiple sclerosis is an inflammatory demyelinating disease of the central nervous system that have dissemination in space, meaning it affects more than one areas of the CNS and also disseminated in time. So it is relapsing. It is first described more than 150 years ago by Professor John Martin Charcot. And so these are some of the MRI features of MS, the dorsal fingers, or on the spinal cord, a short segment myelitis, usually dorsolaterally. So what is this neuromyelitis optica, NMO, or sometimes called the David disease? In neurological textbook, it said it's an inflammatory disease of the CNS that's characterized by very severe optic neuritis, can be bilateral, and a very long, extensive myelitis. Previously, it's thought to be a severe form of MS. So this is Dr. Eugene David. While Professor Charcot was from Paris, Dr. Eugene David was from Lyon, the gastronomic capital of France with a lot of great food. So what is the Dr. David's original case? More than 100 years ago, Dr. David saw a 45-year-old woman with generalized weakness at the Hôtel du Hôpital of Lyon. About a month later, the lady developed acute urinary retention, complete paraplegia, so some spinal cord inflammation. A few days later, unfortunately, she got a complete blindness in both eyes. As we can imagine, more than 100 years ago, someone who is paraplegic, they died from bed sore. So a neuropathological examination was carried out, showed that she has a severe demyelination and necrosis in the optic nerve and spinal cord, but no brain lesion. Dr. David published this case report in a medical journal in Paris. So in the same year, the first Congress of Internal Medicine was held in Lyon, and Dr. David presented his case, and 6 reported cases is collected from the literature in Europe and America. So this is the conference proceedings or the conference abstract book that he's published. His student, Fernand Gore, studied these 17 cases and wrote a doctoral thesis. He first used this term, neuromyelitis optica, or your French maybe is better than me, or if you Latinize it, it's neuromyelitis optica, so NMO, that's how the term came from. Some years later, a doctor from Turkey made some clinical attachment in Paris and called it Melody de David. So now it's called David disease. So in Asia, probably 20 or 30 years ago, we know that in Asia, the prevalence of MS is much lower. But the Asian neurologists at that time, 20, 30 years ago, saw a lot of patients with severe optic neuritis, sometimes can be bilateral. And the myelitis seems to be very long. This patient can have severe permanent disability or a blindness even after the first attack. And they see a very high female preponderance, 9 female to 1 male. Remember that in the multiple sclerosis in MS, the female to male ratio is 2 to 3 female to 1 male. So it's not so high. But the traditional concept at that time is that 20, 30 years ago, the confusion was that in David disease, they should not have any brain lesion. And it is a monophasic, it is not relapsing. So at that time, because some of the patients were having brain lesion, the neurologists at that time did misdiagnose some patients as having MS. And also because the disease is relapsing, some of them were diagnosed as this so-called new entity, Asian optical spinal MS, OSMS. Somehow we have forgotten about NMO, or because the term here is MS, so they were mistreated as MS, given MS therapy, and sometimes with detrimental effect. So it is only until 2004 that a very important discovery by the Mayo Group in collaboration with the Japanese, they discovered an antibody called the aquaporin 4 antibody that is very specific in the NMO patient. So what do this antibody do? In our brain, beside the neuron, there are some glial cells such as astrocyte, oligodendrocyte. If this aquaporin 4 antibody enters our CNS, it binds to the astrocyte. There is abundant in this AQP4 receptor. It causes severe inflammation, damages the astrocyte, and the astrocyte is dead. When astrocyte is dead, it cannot supply the nutrient to other cells, such as the oligodendrocyte. So oligodendrocyte dies and causes very severe demyelination. Very interesting about this paper is that while the discovery was made in Mayo Clinic, almost all of the people here are not originally from America. So it's a very strange. It's from Australian, Canadian, Italian, Irish, and of course a Japanese collaborator. So now we know that in neuromyelitis optica, so the optic neuritis is can seen in the left optic neuritis here, or it can affect the optic chiasm, causing bilateral blindness. The myelitis can be very long, more than 3 vertebral segment here, and another interesting feature is the area postrema syndrome, where the dorsal medulla is affected. There's inflammation in the dorsal medulla, causing intractable hiccups and vomitings. So patient can in fact first present to a gastroenterologist before coming to see neurologists. So now there's a new diagnostic criteria for NMOSD after the discovery of this antibody. We now call it neuromyelitis optica spectrum disorder, because you do not need to have both optic neuritis and myelitis. You just need to have one. So if a patient has optic neuritis and AQP4 antibody is positive, it can be diagnosed as NMOSD. Or a very long myelitis, antibody positive, NMOSD. Or area postrema syndrome, antibody positive, we can diagnose as NMOSD. Of course, there are other rarer features like the brain lesion, which I'm not going to talk here. Some of these patients may have concomitant autoantibodies like the ANA, SSA are positive, but not all of them will have SLE or the Sjogren's syndrome. Is just an epiphenomenon. And the patient with NMOSD have a higher association with myasthenia or some SLE. So this is some epidemiological studies. When the epidemiological were just conducted 10 or 15 years ago, we do not know about this beforehand. Later, when more studies were being conducted, somehow a trend emerged. It seems that the racial group seems to be the most significant factor in determining the prevalence. So among the whites or the Caucasian, it's very low, just 1 to 1.5 per 100,000. Blacks can be up to 10. Among East Asians, like the Chinese, Japanese, Korean, up to 6. Austronesians. Austronesians are the populations in the maritime Southeast Asia, the Filipinos, Malays, Bornean, Indonesians. The Pacific Islanders is about 1.5 to 2. Those with South Asian ancestry, for example, Indians, Pakistanis, Sri Lankan, is again low at 1. Central Asia, study from Kazakhstan, is about 5, so more similar to East Asian. In South America, it's somewhere in between, 2 to 4.5 because of the genetic contribution from the African ancestry and some Native American ancestry. So focusing a bit more about East Asian, so it's about 5 to 6 across for all the studies we have conducted so far. There's no latitude effect observed. And very recently, the Thai group published the study. So now we know that in Thailand is 3 over 100,000. So we are in need of data from the continental Southeast Asia, Vietnam, Myanmar, Cambodia, Laos. So if anyone is doing any epidemiological studies about this and need any assistance, I'm very happy to help. So as we can see, the racial group is a significant factor in determining the prevalence. So it's not wrong that we can see that there'll be some genetic or HLA associations. So among different racial groups, like the Japanese and Chinese, they share certain risks and protective areas. But for other racial groups, there are different risks and protective areas. So why I talk so much about the prevalence about this disease? We can see that in Europe or America, for the whites or the Caucasian, MS has a latitude effect. So let's say in the southern Europe, the prevalence is about 50 for MS. If you go to the north, such as the Scotland, it's about 200. But for AQP4 positive NMOSD in white, it's only 1. So sometimes it's not easy for the European neurologists to diagnose this 1 out of the 100 in them. It's not easy for them. However, at the equator, where we are here, or in Singapore or Malaysia, so we can see a totally different scenario. For those with East Asian ancestry, like the Chinese, there are more NMOSD, 6 to 4. Those Austronesian, like the Malays, 2, this is 9. And those with South Asian ancestry, 1 and 17. So when about 10 years ago, when we are just when the antibody just started to be available in Malaysia, so in my clinic, so we reclassified all our patients, we retested and reclassified. Surprisingly, about more than 60% of our so-called MS patients were NMOSD. So fortunately, we teased this out. If not, then we have some detrimental consequences. So why do we need to differentiate NMOSD from MS? Why is it so important? Because of the treatment implication. Disease-modifying therapy used in MS, for example, interferon beta, fingolimod, or natalizumab, may exacerbate or worsen the NMOSD. So if I give the interferon beta to NMOSD patient, instead of doing good, I'm creating more harm. They can get more relapse. So before the discovery of the antibody, neurologists of the previous generation, including in Malaysia or in Japan, they said they're very regretful. It's a very difficult time for them. They thought they're doing good. They treat the patient, but the more they treat, the worse the patient become. Then they escalate the therapy to natalizumab. The more they escalate the therapy, the worse the patient become. So we hope that this can be stopped now. Since we know about the antibody, we have the awareness of this disease. So in Equator, if there's any patient who are like a demyelinating disease, even though they look very, very similar to MS, please just send a very simple serum AQP4 antibody. Just need to send the blood, no need the CSF. It's very highly specific. If a patient is having AQP4 positive, they invariably relapse. They will relapse anyway. Up to 80% relapse within 2 years. So there's a need for a lifelong treatment with immunosuppressants until we find a cure, hopefully. So if I have been in remission, I have no relapse for 5 years, 10 years, can I stop my therapy? So the answer so far, the data we have is no. A Korean study showed that if the patient, the immunotherapy was stopped, 82% of them relapse within 6 months. So don't stop the therapy until a cure is found. Briefly talk about pregnancy. This is during pregnancy, this is post-delivery. There's a high relapse risk during the first 3 months postpartum. So please continue the therapy throughout the treatment. That's what I will always tell my patient. Also, when continuing the treatment, it also reduces the risk of miscarriage because the AQP4 receptor is also found in placenta. Some patients stopping the therapy, they can have the miscarriage.
Dr. Yan, because of the time factor, please.
Okay, I'll try to be fast.
Wrap up.
Okay, so for acute therapy, if patient came with acute attack, we start high-dose IV methylprednisolone. If they are still having severe, can please initiate the therapeutic plasma exchange fast. For example, the patient came with very long spinal cord inflammation. And for the long-term preventive therapy, there are many therapies that can be used. We do not need to start very high-fi or new therapy. Even old immunosuppressants such as azathioprine can be very, very effective and useful. Most of my patients were in fact just on azathioprine. It's used for the patient with, say, a woman who still want to get pregnant. They can still take the azathioprine quite relatively well throughout the pregnancy. Some were on mycophenolate, a newer therapy at rituximab, and these are very expensive medications which are not available. Importantly is that the disability accumulation is attack-related. If now we can diagnose a patient with NMOSD first attack, if we give the immunosuppress them properly, they will not have further attacks. Very, very briefly to the last few slides. Some of the patients with NMOSD, but they tested AQP4 negative. Then what are they? So after that, we found that there are some patients who have this MOG antibody. They can be present like NMOSD with recurrent optic neuritis, monophasic or recurrent myelitis, or in the pediatric group, some ADEM or ADEM-like phenotype. Some have more special phenotype like the cerebral cortical encephalitis. The female to male ratio is a bit more, is 1.2 to 1, more equal. 30% have pediatric onset. They are very highly responsive to IV steroids. And the relapse rate is not that they always relapse, so long-term treatment may not be needed. So again, we review again the epidemiology and the prevalence. So far, it's about 1.5 to 2. We see a slight signal that among the Indians, it can be maybe slightly higher, but we need more data. So this is again the prevalence table. We added the MOGAD here. So in a clinical practice in Southeast Asia, this maybe have some to guide us where the patient will be. So in summary, for AQP4 disease is invariably relapse, high premium preponderance, high prevalence in certain racial groups, treat with IV methylprednisolone, plasma exchange them fast if needed, and lifelong therapy is needed at the moment, lifelong preventive therapy. MOGAD, about 30 to 50% relapse, 1-to-1 gender ratio, 30% pediatric onset, no clear racial preponderance so far, highly responsive to steroid, and long-term preventive therapy may not be needed unless there's severe or frequent relapses. So this is my last slide. So PACTRIMS is our Asia Pacific MS conference. Some years ago, we held it in Ho Chi Minh City in Vietnam. So this year will be in Perth. So please join us if you are able to attend. Thank you very much.